We've got to get a lot of our priorities extended. So, for example, the Medicare dependent hospital, the low volume hospital program, the rural ambulance add-on all has to be restored and renewed on the March 14th CR in time for the 31st of March deadline.
Hello, one and all, and welcome back to a new episode of The Rural Impact. You know, we are the podcast that works hard to connect the dots between policy and rural everything. I'm Michelle Rathman, and I am, as always, so grateful that you have carved out some time to spend it with us, to listening to these conversations that we, off the bat, we say these are not light subjects, but we do hope that you've heard a few things here, well, more than a few actually, that have helped to enlighten you on various topics. And one topic is something that we're talking about quite a bit right now, which is rural health. So we're dropping today on an off day, a back-to-back episode, one week to the other. And we're doing so because we wanted to make sure that we brought you timely conversations from my time in Washington, D.C. at two very important health policy conferences. One was the National Rural Health Association Policy Institute, and the other was the National Association of Community Health Centers Policy and Issues Forum. Now, if you listened to last week's episode, you know the conversations heavily focused on the very heavy and troubling topic of the potential for draconian, as we call them, Medicaid cuts. And the cuts that will impact rural populations, rural health facilities, and local economies, it's like a triple, quadruple whammy, to be honest with you. And again, because I am recording this on March 10th, you know that by the time you hear this, and as a matter of fact, even while I'm recording it, there will be undoubtedly new developments. But as it stands right now, we know that U.S. lawmakers are battling to avert a March 14th government shutdown with a funding deal backed by President Donald Trump as he pushes his polarizing plan to drastically downsize the federal government. And this includes laying off thousands at HHS, CDC, NIH, and other critically important institutions that serve rural Americans, including our public health and well-being. So you may have heard that Republicans have released a stopgap bill to keep the government funded through September 30th, which is not likely to see support from Democrats, as I've been reading and hearing. But again, let me remind you again that some of the other major issues at stake, of course, besides the potential government shutdown and these massive Medicaid cuts, but there are several issues at stake. And before I introduce our four outstanding guests for this episode and all this flurry of activity, I also want to make sure that I kind of float up to the top of the conversation and have you keep in mind that there are several proposals that are of concern related, of course, to Medicare and Medicaid reforms. But they will also, if they make it to the finish line, we might see some other devastations for rural serving institutions and populations. And these include the potential repeal of the ACA marketplace subsidies. Another one that I see having a dramatic effect, a negative one at that, would be the elimination of nonprofit status for rural hospitals. They are completely different than maybe a big nonprofit system that you'll see in a metropolitan area. They have a very significant purpose in rural. And of course, we're also kind of bracing ourselves for the news about whether or not there will be, and all issues point to this right now, dramatic cuts in the Supplemental Nutrition Assistance Program, otherwise known as SNAP. And we know that for rural children and families, they will suffer greatly if this is going to happen. So I do encourage you to go back to the previous episode if you have not had a chance to listen, to hear from so many experts on these matters, each of them providing really sage advocacy advice. And speaking of sage, it's a great segue to let me introduce you to my first guest in this particular segment. So first up, he is no stranger to the Rural Impact. He's Brock Slabach, nobody other than Brock, Chief Operations Officer of the National Rural Health Association. And I really sincerely mean this. I always appreciate spending time with Brock because he very succinctly lays out the rural health policy priorities that need our collective attention. And when I say collective attention, here's what I mean. I want to share with you that last year I had an opportunity to accept an invitation to speak at the National Rural Broadband Association conference. And I was just asked to give about 20 minutes of my remarks about rural health and kind of the state of rural health. And one of the things that I did was I presented to the body of participants there. I laid out all the bills in which rural health policy has an intersection to rural broadband policy. And I ended my talk by sharing with the audience that they can feel assured that rural health advocates are advocating for rural broadband. And then my question to them was, but what will you do for rural health? And so I put that out there because even if your organization, even if your industry is not directly related to rural health, this is the time for us to kind of share our notes, combine our resources, and really find ways and synergies that make sense for us to advocate for together. So that's what I mean by collective. I just want to make sure I mention that to you. Now, after you hear from Brock, you're going to hear from Mark Holmes, and you might know his name, you might not, but if you don't, he is the Center Director for the Cecile G. Sheps Center for Health Services Research at UNC. Why did I have Mark on? You might wonder. Well, he's going to connect a few more dots for us because we shift the conversation to the connections between research and policy, including rural medical education, maternal health outcomes. Both of these areas heavily rely on federal dollars, now with looming uncertainty. So before you hear from Mark, here is my conversation with Brock Slabach. Are you ready? Let's go. So let's talk a little bit about the priorities for NRHA and what we need to be thinking about. This is dropping in early March, and we've got significant deadlines in front of us. What are you all focused on?
Well, I think that as we look ahead towards March 14th, which is the date that our existing continuing resolution expires, we've got to get a lot of our priorities extended. So, for example, the Medicare dependent hospital, the low volume hospital program, the rural ambulance add-on all has to be restored and renewed on the March 14th CR in time for the 31st of March deadline. So that's a big priority. And obviously we're dealing with a new administration that's in place now in Washington. And so we have a transforming rural health message that we want to bring to Capitol Hill regarding rural health. And it has 5 pieces to that program. The first is focusing on regulatory relief. We think that there's a huge appetite in Washington for the regulations being relieved of our providers to help them do
staff ratios and things of that nature.
Ratios, looking at Medicare Advantage, trying to see where we can maybe get some efficiencies placed on prior authorizations and denial management. The second is secure our key rural health programs. And I'm going to be a bit repetitive now. Those are the Medicare dependent hospitals, low volume hospital program, and then the ambulance add-on, which is huge.
Yes.
And to the point of regulatory relief in the area of Medicare Advantage, it's making Medicare Advantage work for rural healthcare. So we need to figure out a way that we can agree that as we look at Medicare Advantage, it's taken our hospitals and clinics and those that have had these historic programs to guarantee their operational viability. Medicare Advantage kind of goes around those barriers and is completely turning upside down our operations of our facilities. I call it a Trojan horse site neutrality program. I mean, this is ultimate site neutrality if the Medicare Advantage companies continue to not pay attention to the reimbursement that's required for them to operate. The fourth is payment policies that are harmful to rural providers. One of the speakers that we heard this morning, Senator Wyden, was very articulate on the current plans of House Republicans regarding significant cuts to Medicaid.
Yes.
So we've really got to be keyed in on that. And then last but not least is sustaining our rural health infrastructure. We have aging facilities all over the country that need modernization and updating in terms of their physical plants. And so that's the other big piece. We have a bill that we're working on with Senator Bennett's office from Colorado, a Healthcare Revitalization Act. And so that's another one that we're working on. So that's kind of a capsule of what it is that we're focusing on here at this conference for our Policy Institute.
I just going to touch on this last one, the infrastructure. I mean, we are aware of the fact that we have so many aging facilities. We know that climate disasters, we've got, hospitals on the coast that need to be tsunami and earthquake resilient. We've got so many issues, and yet it feels like they have to jump through fire hoops. And traditional funding isn't there for them. We need to make sure that the borrowing rates are favorable and so forth. So when we say infrastructure, you can't put a new piece of equipment in a facility that doesn't have the wiring, the room, building in a healthcare facility is not the same as adding a room onto your house. And I think that we don't educate our members of Congress enough about that.
Yeah, I see this all over the country. We have Hilberton era facilities that are now having to service this
70 years old,
having to service this very modern delivery of healthcare.
Yes.
And our public is very aware of the fact that their facilities may be inadequate for the purpose of what they're working in today. And so we do need to have this. So the Revitalization Act looks at trying to extend 0% interest for 5 years for qualifying facilities, sure, making the cost of money affordable. Because right now, if you go to the open market to get a loan, you're looking at 6-7% if you're lucky. And that's just way too much for these rural facilities.
It sure is. And I want people to understand that there is a connection to recruitment, mm-hmm, and not just of the clinical staff, but people want to work in a facility that meets the needs of modern day technology and whatnot. So there's no escaping the connections, are there?
Absolutely. And another area that's a huge capital investment is the electronic health records systems.
Absolutely.
And that's another area where there's a big, historically, a big investment from the federal government in that program through the High Tech Act. And now we don't have any of those resources coming from the federal government to support all of these electronic health record systems that we have in place in our rural facilities now.
And we know that cyber threats they will cripple. Mm-hmm. They will cripple because there's no safety net, if you will, if a system, we've seen it with Change Healthcare, and rural hospitals suffer mightily as a result. They do not have the resources to get back up.
That's right. I know hospitals around the country that have been crippled because of their attack. And it really is invasive to the entire system. It's not just the fact that they can't log on and, give a medication to a patient. In one case, it took down their phone system. It
yes.
took down a lot of their electronic security right. systems.
Prescribing,
everything in the entire system was completely out of service. And so it costs a lot of money and it costs a lot of time and effort when these things happen.
Great. Appreciate that, Michelle. Thank you. So I think we have to think about it as a spectrum, and there's a timeline to how something like this develops. So we have to have people who understand and observe these gaps. And so, for example, among rural health researchers, WAMI, which is always a fun term to say, but the group out of University of Washington has done some amazing work for decades to chronicle how rural areas have fewer physicians and nurses and just about every healthcare provider per capita than urban areas. Mm-hmm. Well, identifying what's the issue or the problem or the barrier in this case, identifying it is important, but then you have to think about how we're going to follow through and do something about it. It's great to talk about problems. It's much better to actually do something and address them. Mm-hmm. So in this case, some of the work that the WAMI Rural Health Research Center has been working on for years is showing that the best strategy or the most effective strategy for having more healthcare providers in a rural area is to train them in rural areas and to recruit them from rural areas. Mm-hmm. And so this research to understand what are the primary factors of getting people to practice in those locations leads to policy interventions. So for example, one program that was launched about 5-6 years ago was the Rural Residency Planning and Development Program, which has funded a number of, I think, 51 new rural residency programs across the country and helped them. These are places that, have been able to train for years, but it's a lot of work. I've never done it, but I understand it's a lot of work to launch a residency training program and figure out how do we train docs. So there's all these challenges you have to face. How do we find preceptors? How do we build a curriculum? How do we get licensed and get the money and all that other stuff?
Place them in rural communities. So because you don't just plop yourself down there, you have to have time in that rural community and so forth. So Mark, let me ask you this. How are some of these policy shifts, and that's the word we're using, we said shift is happening. How are some of these policy shifts impacting programs such as this? And if they haven't already, what do you foresee? Should there be, let's just say, a pause, interruption, or a decision to not fund this kind of research?
Well, rural health research centers, which are one of the programs of the Federal Office of Rural Health Policy and HRSA, have been highly effective at building this research base that leads to interventions that improve lives in rural communities. And I want to give 3 examples, Michelle. One we've already talked about, and this is WWAMI, as showing that if we train them there, and the federal government launched a program to make it easier to train there. The University of Minnesota has a rural health research center, and years ago they started tracking obstetric or labor and delivery closures. And because of that, HRSA launched the RMOMS program, which is helping rural communities develop a system of care to address that. We at the University of North Carolina have developed a financial distress index to measure what rural hospitals are looking like in their financial sustainability and a prediction for what they may face in the future. And that's been instrumental for a variety of technical assistance programs that the Federal Office of Rural Health Policy has launched to help hospitals that are facing financial challenges. And so with this index, it's sort of like a screening tool. You look and we say, okay, these hospitals are facing some challenges. What can we do to help turn them around? And that's been effective as well. So this is an example of how the research, which is often hidden and sometimes appears to be, they made a nice brief with a cool graph, how that in this case is really leading to, policy that is making differences on the ground.
I don't know about you, I am concerned about what seemingly is kind of indiscriminate saying, if it's research and if there's the word about equity, that's a part of the research, then it's being scrapped. And I think it's important for people to understand that this research has real life implications. The RMOMS program, for example, cannot think of a worse time to curtail or put up any roadblocks to that research and the work that happens as a result of those findings, because we are not, with all the research and with all the interventions, if you will, we still have the worst outcomes of any developed nation. And so I wonder if we talk a lot about the advocates toolkit. How do you see folks that are not in your shoes as a prominent researcher and someone who does this work every single day? How do the rest of us out here advocate to make sure that this research for rural communities is not on the back burner, that we elevate this message and its importance? Are there some pieces of advice you can give our listeners?
Oh, that's great. So there's a Rural Health Research Gateway that's funded by the Federal Office of Rural Health Policy again, and that collects all of the work that the rural health research centers are doing. And so, for example, if you're interested in ambulance deserts, and this is something that's important to you, you can go there and search, and you will find that University of Maine and Southern Maine has been doing some work in this area, and you can see the areas. And the thing about our programs in particular, the centers that are funded through this, is that our work is designed to be accessible to the public. And so there won't be a lot of Greek letters. There will be maps and tables that are real understanding, and trying to make it as local as possible for those who live in Nebraska and have a concern that, they haven't seen an ambulance for a while, and they can pull up they can go to the gateway and find their brief and see this is how we're affected, and reach out to policymakers and express their concern about this. All kinds of topics are available on there for people to look at, and all your listeners, in terms of whatever rural health topic you're interested in, if it's mortality or ambulance deserts or rural maternity closures or health professions or diabetes self-management. It's all up there, and it's a great resource for people to be informed so that they can understand at their community level, what do they need to be focusing on at their state level, at the federal level. Where can we make the differences that we know we need to make rural areas vibrant?
My great big thanks to Brock and Mark for joining me. And now I'm going to make another shift. We do that here so that we can make a few more connections for you. Now, if you have spent any time in rural communities, you have likely seen, and maybe in urban as well, but rural, of course, is what we're talking about here. You've seen a mobile medical vehicle, and they come in many sizes, and those colorful wraps that they're adorned with, well, they bring excitement to the communities that they travel into. And they also bring hope. Hope on wheels, I think, is a best way to put that. From primary care to obstetric care, dental care, and even behavioral health, the use of mobile clinics has become a proven game changer in closing the disparity gaps in rural health. But alas, there is a policy driver at stake here where this is concerned. So up next, you're going to hear from Brad Watson, and Brad is the Chief Revenue Officer from Mission Mobile Medical. And he illuminates us on the subject of mobile medical technology and all of those connections to policy. And from there, I am, again, speaking of illuminating, I am so honored to be able to introduce you to Becky Payne. And Becky is the CEO of the Rippel Foundation. I love the Rippel Foundation name. I love what it represents. And I'm ending this episode with Becky for many reasons, but mostly because these are extremely challenging times. And I feel like a wet blanket, or, I'm just kind of putting the cloud over the day sometimes because there is so much heavy conversation going on here. But we know this. With these challenging times, we know that chaos has a way of disorienting us. And with that, it is essential that we, and I include myself in this, take time to breathe. Someone wrote me an email the other day that said, "Catch your breath, Michelle." And remember that focusing on building thriving communities where everyone has the vital conditions they need for equitable health and well-being, it's far more productive and joyful than the barrage of challenges facing us every single day. So with that, here now are my conversations with Brad Watson and the eloquent Becky Payne.
And so, as most of you know, the community health centers took care of just over 32 million of our neighbors last year. And we believe that using mobile health care to, once again, literally go out into the community, breathe their air, understand how they live, you can bring people into the fold. If they're living their life in the red, just trying to make it till tomorrow, just wondering where they're going to eat or where they're going to sleep or can I take a shower, we can connect them to resources within those communities, maybe get them to just look up slightly at the horizon and participate a little bit more in their primary care.
Sure.
So that's really reaching those that are assigned through Medicaid programs in states across the country, but unseen is a big part of the work that we do, trying to bring people into the fold. And
Yes.
you have financial challenges, you have transportation, you have significant trust challenges, particularly for those that are fearful. They may be undocumented or have family members and they don't want their lives torn apart.
Mm-hmm.
And that's not a fight that we fight. We want to take care of everyone.
You equip people to be able to do that, to take on those challenges.
Absolutely.
I think it's interesting that you say that. I had a conversation with somebody who had a mobile unit through grant dollars, specifically designed to help with women's reproductive health. And they have this great unit. And one of the challenges she told me is that there was such a fear factor for people to go in. So that's a great point that you bring up. All right. So now I want to have a little tough conversation here. Many of those whom you serve, they are able to bring what you have to their communities because of grants.
Right.
We have amazing philanthropic efforts in this country, but we also know that federal grants, other grants, those are essential because what you have to offer, these are not little expensive little mini Coopers. Right. There's a lot of investment in those.
Right.
How do you see, as someone who's responsible for revenue, how do you see the challenges that we're seeing right now with access to grant dollars? Let's just say it continues.
Absolutely.
What will be the challenge for this industry to be able to continue to harness the power of mobile health?
Right.
What do you, if you had a crystal ball?
Yeah, so that's precisely the work that we're trying to do. So we've got about 100 people on our team, both in Greensboro and across the country, that this is what we do all day, every day is try to find opportunity. And so you're right, historically, once again, particularly with community health centers, mobile clinics, and there are around 1,100 across the U.S. that at some point were purchased through community health centers. Most of those were purchased with grant dollars, and most of those grant dollars were funded through HRSA.
USDA grants as well, yes.
But we believe So that do-it-yourself model is the legacy model in mobile health. We believe there's a new way, and that's what Mission Mobile Medical is really we're trying to fill that void. So we're going to partner with FQHCs, and we have a financial model where they are not reliant on grant dollars. We are going to place the bet with them. We are going to put our money where our mouth is and say, if you do this, I need a champion from your leadership team.
Okay.
I need you to allow my nurse practitioner and my clinical staff to plug in to your FQHC almost like a travel nurse, so that we have access to the EMR and can work within your system. And we're going to bring people into the fold, and we're going to get the payers, particularly those managed care Medicaid contract payers that have value base attached to it. We're going to have them help fund the lead activities. So actually the mobile clinic and the work that we're doing. And we believe that we're going to be able to show them significant cost savings on the back end. Mm-hmm. And so rather than grant dollars being almost exclusively used for purchasing of mobile clinics, we think there's a different way. And unfortunately, I've seen dozens with my own eyes. There are probably more than half of that 1,100 that community health centers have purchased are sitting in parking lots, rusting away, not being used because there are significant workforce challenges.
Yes.
And they have to make choices. Do I want my practitioner in clinic seeing 30 patients, or do I want them on a mobile clinic seeing 5? And so that's always been a difficult choice to make. We want to do this work, but we don't have the ability to do it. And that's the void that we're trying to fill, is like, not only do we build the equipment, but we will bring the program and we will help support it. And we are completely below deck. There is no Mission Mobile Medical. It is the community health center itself. We are in support of them. And we believe that we can turn that 32 million into 40 million, 50 million, 60 million of our neighbors, many of whom are very vulnerable.
So the vital conditions for health and well-being are a construct of taking social drivers of health, social determinants of health, and recognizing that we've sounded the alarm quite effectively, but we have not made the amount of progress we should for the degree of effort we've put into them. And what is keeping us from that progress? So about 100 collaborators several years ago came together to pose that very question and get deeply curious and also honest with ourselves as a field about where we were lacking, where we had blind spots, who was missing at the table, and whose voices we needed to bring in. Out of that curiosity came the vital conditions for health and well-being, the Thriving Together ethos. And the key features are that it acknowledges and can hold the complexity of the systems that contribute or detract from our well-being. At the heart space of Thriving Together and vital conditions is belonging and civic muscle. And
I love that word. I want to say it, civic muscle. That is not a phrase that many people kind of toss around. So
I'll explain it.
Explain that for us.
Yeah. And belonging and civic muscle go together by design. They are the heart space. Like I said, we show the framework as a circle, and belonging and civic muscle is the center piece of that circle. But it's also a superpower of the framework because we have data and models that show, and anecdotal stories from communities all across the country, many of which are rural, that when you invest in belonging and civic muscle alone, it creates sort of this virtuous cycle of expanding the pie. So in times when we are so focused on a scarcity mindset,
yes,
and told we can't do things because there isn't enough to go around, we often find if you help people shift their mindsets and get curious about who feels like they belong, who feels like they are valued, that their voice is genuinely taken into account and have a genuine, I don't even want to say seat at the table because I think that is often sort of a check the box approach, but they actually feel like they are valued and loved for who they are in their community, for all the experience that they bring. Then we recognize when they start to feel like they belong in a genuine way, you untrap the rich assets of those individuals, those populations. Often find that there are organizations that they've been a part of that have been taking care of their community in ways that have not been tapped into in those communities. And the more you do that, the more you reduce the reliance just on traditional sources of resources and funding that, as we know, can be very fragile,
yes,
episodic,
yes,
not long-term enough.
Transactional.
Exactly.
Yep.
So when you invest in belonging and civic muscle, suddenly you start to form those social connections that we keep hearing about. We are so lacking right now that are causing mental health crises, substance use crises. But when you invest in them, you start to reduce those. And civic muscle is, you can think about a muscle that you can build and you can practice and you get better, you get stronger the more you do it. It's not just voting. Voting is very important, but it is everyday opportunities to contribute to your community, to use your skills and talents in the ways that make sense, whether that's through volunteering, whether that's for mutual aid, whether it is multi-generational sort of care networks, and just getting to know the fabric of your community again, returning to the places where we gather, returning to collectively taking care of sometimes what's referred to as the commons, but we all recognize the town square, the community, your neighbor, your block, organizations. So belonging in civic muscle is a critical feature to both recognize, understand, and then celebrate as, like I said, a superpower. And it's a virtuous cycle between the two. When you invest in that, then when you think about the remaining 6 vital conditions, things like humane housing, reliable transportation, a thriving natural world, lifelong learning, meaningful work and wealth, and of course, basic needs for health and safety, which is where you start to see access to medical care, adequate and robust mental health and behavioral health services, all the things you think about in healthcare. Those then, when you have belonging and civic muscle at the heart, those start to be reimagined, understood, and redesigned in ways that anchor in equity, that have a better chance of addressing the disparities that we're seeing, and start to create the conditions that don't keep us in this dependency on urgent services. So things that we all need in a crisis.
Yes, I like running around burnt buildings with a net waiting for people to jump. And that seems to me to be kind of how we've been operating for so long.
It's absolutely necessary when you have fires and floods and hurricanes. Of course. Pandemics. We never want to suggest that we can get away from a need for urgent services. However, our mental models and our systems have become all too reliant on thinking that investing in urgent services is enough. There's no amount of investing in urgent services that will ever shift us to well-being. Mm-hmm. That's where the vital conditions come in. And so our work as a foundation through Rethink Health, through our partners, is to be a catalyst to share what we've learned about the power of this model, about the power of the model to help us think differently, to get out of transactional solutions, to think 20, 30 years generationally down the line about what investments today could mean in generational terms, and to help support courageous acts of what we call stewardship. So not necessarily traditional leadership, but actually thinking of ourselves as stewards. Yes. And we then add another feature to that, which is shared stewardship. So if you think about thriving together and shared stewardship, the language is very intentional. Yes. Because it starts to help us remember that we are only going to thrive when we do it together, that any amount of struggling and suffering in our community is actually also painful to me, even if I'm doing well. So we have studied and understood who embarks on this kind of transformational change. How do they do it? What are their characteristics and skill sets? And what are the tools and resources that can support them in that? Mm-hmm. Shared stewardship is the skill set. We can teach it. We can measure it. We can talk about it and share stories and uplift those bright spots.
And I'll just say the thing about it is shared stewardship and the kind of civic muscle that you're talking about. These are the things that cannot be legislated. You know, these are the things that aren't born out of policy. They're, in my view, these are born out of, you said the word curiosity, commitment, and things of that nature. But it seems to me that once you have that, that's where you're able to plug into that which the resources that come through policy. And we talk a lot about capacity building. And I have to be honest, I'm kind of tired of the phrase.
Yeah.
I like your framing better.
Well, so I'll challenge the assertion that policy can't be an effective lever.
Okay.
So I come out of 20 years of policy work inside of federal government and state government, and we continue to work with policymakers. there is a role for policy to enable these conditions. And we've worked quite extensively with over 50 agencies to think about how they could change the way they work without new funding, without new authority, but think about their role in returning the assets of the federal government to communities. We've done this now spanning 2 administrations.
Wow.
So there is a role for policy to help think about the way resources are allocated and the flexibilities that communities are given through data access, through technical assistance and training, and yes, through grant funding and other types of federal resources flowing to communities in ways that enable this locally informed, locally controlled approach to thinking about long-term investments. There are ways to untrap the policy levers to make that happen. And it is bigger than government, whether it's state, federal, or local. There's also a critical role for civil society to play. And I think that's part of what is so elegant about Thriving Together and the vital conditions, as it helps to hold the complexity of those systems, makes it visible for folks who don't really need to become experts in complexity, but it sort of logically lets you reflect back. What is the fabric of our community? Why is it so hard for me to go get access to care? Well, gee, you don't have humane housing, reliable transportation in rural communities in particular. Those barriers can be so high, but the vital conditions isn't a deficit model. It sets an aspirational view of a hopeful future of what could and should be. So you can benchmark where you are today, and you can pull all of your stakeholders across government and non-government partners and community members and say, if we understand how all of these interdependent pieces fit together and where we stand today, and we know where we need to go, then we can start planning together in a fundamentally different way. And the framework is just a framework. There are so many.
Yes.
It's only as good as the organizing and the building of community that you do. But we have found that it is a powerful glimpse into the complexity of a community, but in a way that everyday people can grasp, so they don't have to become experts in anything other than their lived experience and how the world around them is impacted.
I really appreciate Becky's words of wisdom. We have abundant examples of framework, but as she says, it's only as good as the organizing and the building of community that you do. But we have found that it is a powerful glimpse into the complexity of a community, but in a way that everyday people can grasp, so they don't have to become experts in anything other than their lived experience and how the world around them is impacted. Again, really appreciated her wise words. Very inspirational during these very challenging times. My thanks to all of you for joining us. An important reminder to visit theruralimpact.com to subscribe and to visit our resource page for each episode, where you're going to find links to guest websites, articles, policy updates, everything that we can find to be a resource to you. And you know, we always do appreciate it when you rate us on your favorite podcast channel. We are everywhere we can think of, including YouTube, in case you'd like to watch us as well. As always, leave a comment. We love when you send us your notes. I do appreciate you reaching out to me on LinkedIn. You can find me there in Blue Sky. And we would love to hear from you there as well. My thanks to Bria Corsaro and Sarah Staub for their hard work behind the scenes, as always. And until we're together again, here's an invitation for you to take extra good care of yourself and everyone else around you. We'll see you the next time on a new episode of The Rural Impact. You have just heard another Rural Impact conversation focused on rural health, but the conversation isn't over, because you are invited to reserve your spot at the 2025 Pennsylvania Public Health Matters Conference, where the focus is people, strategies, and policies to advance healthy communities. Now, the event is taking place on April 15th, 2025 in State College, Pennsylvania, so it's important that you register by March 31st, or you're going to miss out on opportunities to attend this information-packed one-day event that brings together public health professionals, healthcare providers, researchers, students, and community members from across Pennsylvania and the region. Whether you're passionate about community health or migrant health, involved in healthcare delivery, or seeking insights into emerging public health strategies, this remarkable conference is definitely for you. Now, again, the deadline to register is fast approaching, March 31st, so visit the Pennsylvania Public Health Association website at pa-pha.phmc.org. That's pa-pha.phmc.org, or just visit the Rural Impact website and check out our resource page for a quick link to take you right to the registration page. Because public health matters to you, we'll see you at the Pennsylvania Public Health Matters Conference on April 15th.